Now we go to the last speaker of our course, Dr. Vinod Arora, and he requires no introduction. Um, he's going to talk on advanced surface ablation. Gone are those days when we were worried about pain and haze and all the complications of surface ablation, because surface ablation has come a long way. And let us hear from Dr. Arora what is the magic.
So basically the things don't die, they come in other forms, and we have got the old neglected PRK back to in the main surgery. So we evolved from RK, AK, PRK, LASIK, interlace, epilasic, smile, contour vision, and again we have come back to advanced surface ablation. So PRK was more accurate than RK. It was able to treat myopia, hypermetropia, it was stable, but the problem was it was causing more pain, there was a delayed healing, there was a risk of scarring much more common in those days. Then came LASIK. There was a rapid recovery, wow factor, decreased risk of scarring, no pain, but some complications like flap striae, buttonholing, partial flap, debris epithelial ingrowth, DLK, late trauma, and ectasia were common in this condition also. Then came the femto. We have got much thinner flaps. There were fewer flap-related complications, but some problems like persistent photophobia, rainbow effect, higher DLK, late trauma, and ectasia were still there. Then came the smile. It is a good technique, but there is a lot of limitation at present. There is no hyperopia correction, customized treatment like topo-guided, wavefront guided treatment not possible. Difficult in low power correction, bitoric, mixed astigmatism are difficult. Treatment is centered on the pupil. No cyclotorsion compensation. Little decentration on the femto will have no effect because it doesn't have refractive component, but a smile it will affect a lot. Then came the advanced surface ablation. There are some special indications where we can use advanced surface ablation, like in FFKC, if there is irregular astigmatism, if the cornea is thin, if there is night vision concerns like glare from glasses, pupil or flap, if there is anterior stromal opacities, if there is a person involved in the contact sports like hazardous duties, if there is a prior RK or AK, if you want to do wavefront treatment, remember if you may take a thick flap, all the wavefront things get disturbed. But if you're doing it on the top, you're getting the maximum correction. Then the patients like RD surgery, filtering blab, deep set eyes, was difficult to put a ring. Then you can combine it with C3R. So we have got various presentation, and PRK is supposed to be the minimal chances of ectasia there compared to all the things what we are doing at present. So these are the studies, I'll not go. But we can combine it with we can combine CXL with PRK. That's again a big advantage. Basically, it's a topo-guided treatment. And already we covered that we just treat the aberration part only in this. We don't treat the spherical or cylindrical, whatever is there. Our aim is not to treat the refractive correction. So we reduce the parameters and do the things. I'll not go detail. So why there was haze in earlier PRK cases? So we were doing more than 6 diopter correction if we are trying to do hyperopic correction. If the ablation depth was more than 80 micron, smaller diameter ablation. If we are doing a retreatment or the previous corneal surgery, these all led to corneal haze. The normal surgery was like this. Local anesthetic drops. We are removing epithelium by Omail's brush or what alcohol assisted or the manual removal. When after removing epithelium, laser was applied, and then came the mitomycin, which changed the game at all. And we put the bandage contact lens, antibiotic lubricants. This is the usual PRK we were doing earlier. The complications which were common are stromal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosion, which may cause significant discomfort, epitheliopathy. So how we can improve the results in advanced surface ablation? That's very, very important. Careful pre-operative checkup is again important. Blepharitis is there, we have to make the good lid hygiene, scrubs and antibiotics. If it's a dry eye, we have to use artificial tears, cyclosporin drops, ointment or puncture plugs. Dry eye is more common in middle-aged patient. We use tablet prednisolone just for 2 days, not for 1 week. Sorry, when operative, we have to use mitomycin, which was a game changer. We use chilled BSS. Proper fitting contact lens is again important. If you see any debris on the day 2 or 3, just change the contact lens. That's very important. Contact lens soaked in AccuVel or AccuSet is supposed to be reduce the pain. Of course, AccuVel is not available and we are using AccuSet. Then there are newer contact lenses are coming which are biodegradable. I think that will be again more beneficial. NSAID should not be used directly before putting contact lens and don't use too much. Mitomycin C is a potent antimicrobial that inhibits DNA, cellular RNA, and protein synthesis. It blocks keratocytes activation, proliferation, myofibroblast differentiation, and subepithelial collagen formation. So that's why it's result in stromal scarring. Again, we have to avoid overuse of topical anesthetic. Don't give any anesthetic. Oral steroid should be restricted to 2 days. We have got better painkillers now. Anti-seizure medication like gabapentin or pregabalin are very potent. Avoid aminoglycosides as they are corneotoxic. We have to improve the epithelial regeneration, doxycycline twice a day. If there is epithelial defect, avoid UV exposure. That's again very, very important. Normally what happens, we just say buy a UV goggles. That may not be perfect UV blocker. So it's the best if you can provide yourself. That's the best option. Sorry. Then nutrition supplement is always helpful. What has changed now? Why has come in the big way now? Because we have got the better techniques to remove the epithelium in a wavefront optimized way. So it's a smart surface technology from This is giving a very smooth surface. Then streamlight from Alcon. So how the pattern has changed? Basically, this is the slide. You can see what we were doing earlier and what we are doing now. This is practically PTK is in neutral. It doesn't causing any change, and epithelium is totally removed. It's a totally one-step procedure, and that's why we have increased our limits. Normally, I am doing up to -10 spherical equivalent. You can correct myopic astigmatism. Hyperopia can be corrected up to +3. Even the astigmatism, mysticism. So practically, we are covering whole the range with advanced surface ablation now. This is a one-step, no time lag. First epithelium removed, followed by refraction, optical zone selection. Sorry, which corresponds to refractive correction, less myopic shift compared to standard PRK. There is an optimized epithelium removal. That's the crux of these newer software we got. So epi-ablation zone automatically will be determined by laser based on the PRK ablation profile. There is an active eye tracking system throughout the entire process. So what are the advantages of transepithelial PRK as such? It accelerates healing by visual recovery by limiting minimum epithelium removal. There is less pain, reduced risk of haze by accelerating healing, by smooth surface, better contour, by removing damaged cells and reducing thermal effect. All these add to reduce risk of haze. Thank you. The shortcoming, the flip side is that it accentuates the importance of epithelial mapping. You should have a OCT which has epithelial mapping capacity. It causes more heat. It's still not available with premium profiles, like you can't do customized treatment. It has a price tag. You have to use a card. So overall advantages of surface ablation is it's a gentle, no touch, no cut, no incision. It's a very safe, more biomechanical preservation of the cornea and stability. It's a stress-free, faster treatment in a single step. No effect on the posterior segment. That's again important. Excellent clinical outcomes. Reduces dry eye by leaving the nerves that produce tears intact. Can be combined with CXL And it's a very economical, you don't have to use other femtosecond or microcotome with this one. It's still underutilized and have a great potential. Thank you very much.
Excellent talk, Dr. Arora. Very informative, and probably you have touched the future of ophthalmology. We should not go by the need of the patient for an early recovery, but comfort is going to get whole life with advanced surface ablation. Thank you.